You're listening to the Knowledge Archives podcast. Welcome to the Knowledge Archives podcast. We're a group of students on a mission to learn from as many different disciplines as possible. I'm your host, Eileen Freinud, and today I have the pleasure to be joined by Dr. Laura Adery, a postdoctoral clinical psychology fellow in the UCLA Peers Clinic and a postdoctoral scholar in the UCLA Department of Psychiatry. She has worked with individuals with developmental disabilities in both research and clinical settings, with special interest in inclusion in the arts and cultural community through work with the ACM Lifting Lives Music Camp in Nashville, Tennessee. Her postdoctoral work focuses on expanding treatment and intervention resources and investigating self, identity, and community inclusion for adolescents at risk for psychosis. Thank you so much for agreeing to have this call with me today. I'm super excited to learn more about your work and what you've been up to. Just in general, to kick things off, could you give a brief introduction of yourself and explain your research interests?
For sure. And thanks so much for having me. I think it's such a cool project that you're working on, so happy to be a part of it. So yeah, I'm Dr. Laura Adery. I have a Ph.D. in clinical psychology, and I am currently a clinical instructor at the University of California in Los Angeles, working in the psychiatry department, and in particular working in the Center for Assessment of and Prevention of Prodromal States, so we call it CAPS. And so I've been there for the past 2 years now. Primarily, as it sounds like from the name, we do assessments and we provide treatment and referrals for youth kind of age sort of 12 to 34, with some exceptions, who are experiencing some symptoms of sort of like what we call prodromal psychosis, so sort of attenuated symptoms of psychosis, that they come to us looking for answers and for diagnostic clarity and for kind of referrals and support with that. So that's what I'm doing currently. It's interesting because it is part of a research clinic. So we were part of a large consortium of research teams called the NAPLS, N-A-P-L-S, North American Prodromal Longitudinal Study, which just ended just a few months ago. But as a part of our clinic, the very cool thing we get to do is that as we're helping individuals, we're also collecting data so that we can understand better who are those people who are most at risk for developing full psychosis, so that we can kind of help also people in the future.
Mm-hmm. So I know like a large focus of your research is on psychosis specifically, but I think you've alluded slightly to this already, but what are some of the main projects that you're currently working on or have worked on in the past? And you can talk through as many as you want.
Sure. So as I mentioned, the clinic that we have at UCLA is doing ongoing research on kind of improving our predictors of who converts to psychosis. So we know kind of across the board, having sort of a lower level perceptual abnormality or kind of disturbance of reality in some way, some unusual thought content, things like that, are not so uncommon. They kind of lie across a spectrum of experience, like most things for humans. But when they become distressing and impairing, those are the people who are oftentimes seeking help from us. And so what we're looking at is how can we best predict who of those people will go on to develop a more full disorder. We know at this point from our previous research that across the board, about a third of people who come to us with those types of symptoms may end up developing a more full psychotic disorder. About a third of those people may have that kind of range of symptoms for, long standing, but be able to work towards managing them. And then about a third of people, symptoms do remit. So what we know across the board from our research is that early intervention helps for outcome in any of those cases. And so that's kind of the main project we're working on, is identifying more better predictors. So with that, we do the clinical assessments, and we also do some imaging and take some biomarkers like saliva. So currently, we know that there's certain symptoms that have a higher likelihood of someone developing a full-blown disorder, and we're working to find out more about that. And I will say another project that sort of my own research has focused on in the field of schizophrenia is looking at social isolation and loneliness. in people who are experiencing schizophrenia. That was what my dissertation research focused on. And quite interestingly, there's a hypothesis called the social deafferentation hypothesis by Ralph Hoffman that essentially posits, just like phantom limb. I don't know if have you heard of phantom limb syndrome before? Are you familiar with that term?
No.
Oh, okay, so phantom limb syndrome, it's very interesting as well. There's a great TED talk on it. But essentially, when the brain doesn't get the expected input from its environment, it can, in some cases, kind of fabricate or create that sensation on its own. So in phantom limb syndrome, this is a kind of well-studied phenomenon where people who have maybe lost a limb, they do experience pain in the place where the limb would be, despite the fact that there is no limb there, and other sensations as well. So the social deafferentation hypothesis is essentially kind of extending that idea that in the absence of a kind of necessary and an expected sensory input, in this case, social stimulation, social connection, the brain may fabricate or overcompensate by creating meaning when there is none. And so that's the idea here, that basically people who experience symptoms of psychosis, especially hallucinations, so seeing things that maybe aren't there or hearing things that aren't there, they're highly social in nature, these experiences they have. And so the idea is that it's possible that there's something about the missing social experience that could be exacerbating, could be kind of worsening or inciting this type of experience. Because what we know is that the population of people with schizophrenia, they have a very high likelihood of feeling lonely and of not receiving adequate social support. And in fact, in a longitudinal study recently done in Australia, about 80% of participants with schizophrenia endorsed pretty extreme loneliness, with that being kind of their top concern after financial concerns for the year. So there's kind of a big misconception that people with schizophrenia don't desire social interaction. One of the symptoms can be social withdrawal, and so people might think that they want to keep to themselves, or also there's a lot of stigma involved, and so people become ostracized because of that. And really what my research project was looking at was demonstrating, first of all, that we can induce sort of these abnormalities or this tendency to over-endorse human motion in random noise when someone's isolated or ostracized. We did that in healthy controls. And then we looked at patients who had schizophrenia, and we saw a correlation or sort of an association between their positive symptoms, meaning like hallucinations, delusions, and things like that, and their amount of loneliness. So the final research projects that I worked on there was developing some potential treatment programs that could help to alleviate loneliness, to see if we could make a difference in symptomology. And there we worked on two different arms, one being a social skills training in a virtual reality, so that they'd have the opportunity to practice in sort of a game-like fashion, practice social skills. And then the second arm was actually a social inclusion intervention, where we had a choir and we sang together as a group weekly, and found that significantly reduced loneliness and improved well-being factors for those individuals. So kind of looking at some low-cost, low-burden potential kind of interventions that could be used to really address these pretty serious problems.
Mm-hmm. I just wanted to focus in on schizophrenia specifically, and I know you were mentioning a little bit about like stigma and stereotypes surrounding this disorder, but I know personally I'm not too familiar with exactly how this might affect people's lives. Like, what are these myths and what is reality about schizophrenia? So I was wondering if you could clear up some common misconceptions about this issue.
Yeah, that's a great question. So yeah, as I mentioned, there is this idea, and I think it's changing more and more as, loneliness is becoming a more discussed topic kind of globally and for all humans, especially kind of in light of our current situation with social distancing. So people are really starting to understand the pretty intense impacts of loneliness on both physical and mental well-being. But so for people with schizophrenia, one of the symptoms that they can experience is social withdrawal, and also anhedonia, which is a fancy way of saying a lack of pleasure, or a lack of ability to expect pleasure. So some interesting research that has looked at this has found that, in fact, patients with schizophrenia or individuals who have schizophrenia, it's not that they don't experience pleasure necessarily in social interactions. And of course, all humans are on a kind of a spectrum of need for affiliation, need for socializing, right? I'm sure we all know people who kind of love to socialize and people who kind of need to recharge and have their own time. And of course, in people who are experiencing schizophrenia, there's no difference in that spectrum. But overall, kind of, I think there's a misconception that people, because of the social withdrawal, don't enjoy social interaction or don't want it or don't need it. And that's simply not the case. There's some studies that have shown that they may have difficulty expecting their amount of pleasure, but that they don't experience a deficit in pleasure while socializing. And also sort of, I think, because of the social withdrawal and of kind of some of the unusual maybe symptoms or experiences that people just don't really understand what's happening. If you see someone, for example, talking to themselves, people tend to, because of the stigma or because of the unfamiliarity with that type of experience, they tend to sort of exclude or stay away from those people. And that can also, lead to more isolation. But in general, that's a misconception. And in fact, people with schizophrenia are more lonely than the general population and do desire social interaction. And another, I think, big misconception is kind of surrounding violence. So, there's a lot of media that portrays someone as like psychotic or violent towards other people. And the reality there is that actually people with schizophrenia are likely to experience violence from others than to perpetrate. And so in general, on average, people who are experiencing these symptoms are, more often than not, like pretty afraid and distressed themselves. So it may look like they are kind of animatedly, either talking to themselves or working something out. And people may think that this means that they're a threat. And in reality, as I mentioned, people with schizophrenia are not, on average, likely to be violent towards other people.
Yeah, for sure. It's really good to clear up these misconceptions, because I know just normally you don't really hear too much about disorders like this. And I think it's super important to learn about what people with psychosis or schizophrenia are going through. With regards to your research, I was wondering sort of how you go about the whole experimentation process, and what are some of the tools or methods that you use to conduct your research. I know you mentioned imaging already, but I thought it would be cool to learn more about what that process looks like.
Sure. Yeah. So the imaging side of things, we take both resting state data, which basically means, so someone goes into a scanner, an MRI or an fMRI scanner, which is a magnetic resonance imaging. So it's to take a high resonance picture of essentially the blood flow in your brain, oftentimes. And the idea is that we take a resting state, meaning you're not doing anything, you're just kind of sitting in there, so we can get sort of a baseline picture of what the activity looks like in your brain. And then we might give you a task to do so that we can measure what is the difference, or what is the change in activity, or where is the most activity happening during this task. And then we can look at, are there differences between different groups of people in terms of what their brain activity is doing during a task or during resting state. And also, are there functional differences, meaning are there actual differences in the way that they do the task, but also are there structural differences? So are there differences in the way that their brains look? So that is one kind of tool that we use. And I'm not a kind of an imaging person myself, so I don't tend to do that aspect of the project. Cool thing about a big project like this is that you're on a kind of a multidisciplinary team with different people who are experts at what they do. And so you can really come together and do a lot of, kind of bigger work than you could on your own, which I love. And then another tool that we use, in fact, for the clinic I'm in, it's called the Structured Interview for Psychosis Risk Syndrome, or the SIPS is what we call it. And that is a diagnostic tool or an assessment tool that we use for every participant that comes in. We're conducting this interview and we're asking the same types of questions to everyone to find out kind of what experiences they may have had that are in kind of 5 different categories. One being perceptual abnormalities, So things like seeing or hearing things you're not sure are really there, tasting or smelling things that others don't smell or taste, feeling unusual types of bodily sensations like pressure, pulling, tingling, things like that, that are confusing, or that, doesn't seem like anything caused that. Unusual thought content is another thing we're measuring. And so things like having the experience of time changing in a very unusual way, or having thoughts about whether something else is controlling your thoughts, or putting things in your head, or taking things out of your head, being able to read minds, things like that. Suspiciousness and paranoia is another facet that we're measuring. So kind of does someone have any ideas about others having an intent to harm them, or feeling very mistrustful of others for some reason. Grandiose ideas, which is essentially kind of an inflated sense of self. So someone might have the thought that they maybe are sort of chosen for a very special role by God or another entity, or that they have special powers. And then disorganized communication is the last realm that we're measuring there. And that's looking at, just are you able to organize your ideas and communicate them effectively to others? And so that looks like sometimes people are sort of blanking out in the middle of talking and not being able to remember what they were saying or where they were going. Or maybe they are kind of starting off on track, but then they sort of get really tangential. They kind of go off the track of conversation and don't realize that they're talking about something totally different. Or just having trouble organizing thoughts to speak out loud, like that they're feeling like things are scrambled or mixed up in their minds. And then, things in terms of, related to data collection that we use. We always are analyzing these data points that we get, kind of finding averages through use of statistics to kind of make generalizations about the on average, the population we're studying.
And so, since so much of your research relies on participants, I was wondering, given our current situation with COVID-19, how your research has been affected, and also, what are some changes that you've had as a result of this whole pandemic happening?
Sure. Yeah, that's a really interesting question too. So we've been actually really lucky with our current study that a lot of, at least the clinical side of the research that I'm involved in is, the interview process. And so we've actually, and pretty quickly, we actually kind of moved everything online to virtual. And we're able to kind of continue conducting those interviews online through Zoom. In some sense, there's sort of some interesting advantages to this because, we're a clinic at UCLA, which is not as easily accessible for all people who want to or might be interested in coming into the clinic. So being able to do it over Zoom kind of provides that accessibility in some ways. And then for myself as a supervisor, it's kind of interesting because now, there's graduate students and trainees that are conducting these assessments, and the way that I can provide supervision for them, or kind of like be training them in the assessment, is kind of cool because I can observe them through the video, and even like send them suggestions of things that they might want to say or questions to ask, so that it's a more seamless interview process for them, as opposed to kind of having to stop and ask me a question and then pop back in or something like that. The other sides of the research have been on pause. So imaging is something that has been on pause this whole time. The Imaging Center is just starting to ramp up their research with a very strict protocol in terms of very limited amounts of people. So no one from in fact, no one from individual study projects is imaging on their own right now. Just the two technicians who run the place are doing that, and temperature checks and all of that. So they're just starting that back up. And then the neuropsych side of things is also on pause right now because there's a lot of instruments that we use that need to be done in person for the neuropsych. So that's like cognitive testing that we do. And so that we're also kind of finding creative ways to do the tests that we can, and then putting on pause the ones that we can't until we can.
Mm-hmm. Oh, that's good to hear that you've been able to move most things online, and that you have been able to continue with the research. It's really good to hear. So, last question for today. But looking back on sort of your entire journey, I was wondering what made you decide to study psychology?
Oh, that's an interesting question as well. Yeah, so I started out. I think I knew pretty early on I was interested in psychology because I've always been sort of curious about people and about differences in people and about kind of different ways that people think and behave. And so I got really interested in that and took some classes actually in my first year of undergrad that really interested me. So I took Psych 101, I took abnormal psychology, which is sort of, the clinical psychology, psychopathology type class here, and got really interested in that. And then from there, I thought I wanted to get more involved. And so a research group had come to speak at a lecture that I was at in my psychology class about their research. And I just went up to them afterward and said, I'm really interested in what you're doing. They were working, it was the mood and schizophrenia lab, actually at the University of Michigan, so not too far from you. And so I kind of just went up to them after that lecture and said, I'm really interested. And, are you taking volunteers to help out in the lab? And they said yes. And in my experience, lots of labs are always looking for undergrads who are willing to volunteer and wanting to learn kind of more about the research process. So if anyone is interested in that, I highly recommend just don't be afraid to just go ask or to email, the PI of a lab you're interested in. But so there's kind of where it took off for me, is getting more involved in research and really getting passionate about the field of psychology in general, but also about, psychosis and schizophrenia. It's kind of a more misunderstood diagnosis and really a lot to learn and a lot to be supported there. And so that's kind of what drew me to that.
Mm-hmm. Yeah, well, thank you so much for agreeing to do this call with me today. I definitely learned a lot throughout this conversation. And before we end things off, if any of our listeners want to ask any questions or if they'd like to speak with you or anything along those lines, where could they connect with you online?
Sure. Yeah. So great question. We have a clinic website that would be the best place to go. And that's at semel.ucla.edu/CAPS. So it's semel.ucla.edu/CAPPS. So that talks a lot more about the clinic, and there's contact information there. So if anyone's interested, I'm more than happy to give guidance or answer any questions. I had lots of support from people along the way to get where I'm at. And I think that that's the beauty of our field, is kind of lifting up others along the pathway. And so it would be my pleasure. And thanks again for having me. This was really fun.